Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Today we have back with us our special guest, Dr David Maplesden, who's an experienced GP in the Waikato. David is also the in-house GP expert for the HDC. So welcome back, David. We really appreciate you spending a lot of time with us.
Thank you.
And back with us again, we've got Dr Tim Cookson and Dr Lucy Gibbard, my colleagues at MPS, and all of us are GPs.
Hi, Sam.
Hi, Sam.
So, David, thinking about the interface between primary and secondary care, do you have any comments about common issues for GPs and hospital clinicians, if you want to comment about them, about how to practice in a way that protects the patients and ourselves?
Yeah, I mean, there are quite a few issues. So number one that comes to mind is the issue of referrals. From the hospital clinician point of view, my perception is that there's quite a variance in quality of referrals in terms of content, clinical content that I see, that then influences, obviously, the patient's subsequent clinical course. So extremely commonly, and I can understand why this happens, is the old cut and paste of the last X months worth of notes or whatever. If I was a hospital clinician, even not as the hospital clinician, it takes me some time going through the referral like that to actually determine, well, what are you actually asking? What is the issue? So I think quality of referral is possibly an issue from the hospital clinician point of view. Referrals in this current health climate, I think we just need to be cautious about our perceptions of when treatment or review should be happening versus what actually happens. And that's, again, very context specific. So if I've got a patient who my gut feeling is that they might have a cancer, I would tend to, for example, to track that referral right to the point of getting the FSA, First Specialist Appointment result back, because I've seen many cases where receipt of the referral is acknowledged, but then something happens within the secondary care system and they never get seen. So I think look at the clinical context and make a decision there on if you're suspicious that this is some sort of time critical review, then there is some onus, I think, on you as an advocate for the patient to ensure this review takes place in a reasonable length of time, what you might perceive to be a reasonable length of time. And we can discuss that further because I know there's a whole lot of issues around that. The issue of what to tell patients around when you might expect to be seen. And, again, we get a report back saying they've been P1 or P2 or whatever. I think there needs to be really a much more explicit directive from secondary care that P1 equals maximum of X weeks wait, or P2 equals X weeks wait, that we can then tell our patients. But in the absence of that happening, and I certainly don't expect that a GP is going to know what a P2 means for orthopedics versus neurology, say, and that is fluid within itself and varies between Te Whatuora districts. I think it comes back to you thinking, I believe this patient should be seen really because of this clinical scenario, ideally seen within 3 months. So therefore, I might set a reminder to check that they have been seen within that time, for example. It's a pain in the backside, but I think we've just got to acknowledge A, the health climate that we're working within, but B, that really we are advocates for our patients, that our patients are important. So referrals, lots of issues. I think the other issue that comes up is making sure that you offer the private option, particularly if you're aware that there might be a delay in the patient being seen for an FSA or for a procedure or investigation of some sort. And I've been guilty in the past of thinking, this person couldn't possibly afford private care, therefore I won't even bring it up. But that's an erroneous assumption. You can't assume that people's priorities are different. So I think it's just worthwhile keeping that in the back of your mind, that there might be another option that might be more timely for this patient and really should be considered.
I think part of it would be actually documenting that, because a lot of us might mention it in passing, but I would personally really document that I've asked them about private.
Oh, that's interesting. I do.
You document that?
Document that they.
Yeah, I think I should start documenting that. Just think about the fact that but now that I'm using a transcribing service, it's pretty easy. But yeah, I think that's important, because it's those small details, if you're writing your own clinical notes, that is so easy to not put in there.
Yeah. And although interestingly, I often see that patients bring it up in their response, the fact that they were offered it, and it's not in the notes. So it can work both ways. That also from a previous discussion we've had in the past about AI, it hasn't happened much to me yet, but what is going to be an issue in the future, I think, is AI ostensibly heard everything you discussed and has put it in the notes. You're now saying that we actually discussed this, but it's not in the notes. Does that, is it black and white now that because it's not in the notes and it was a transcription service that it didn't happen?
Yeah, that's an interesting question. I think so. You can keep your transcriptions for a varied length of time, and some doctors aren't going to keep them, particularly if you're going to, if it's years down the track, who wants them. But I guess that's why it's so important for us to check the summarised notes before we cut and paste them into our PMS to make sure all those details are correct. I mean, as we talked about in the last podcast, it is, there is hallucination and there are some things missed out.
Because they're trained mainly on, at the moment, mainly on clinical aspects, so they pick up all the clinical stuff. But the social things, I understand, certainly in the early versions, are often completely ignored by the
they're really big on social. I've always got the social history in the notes. Now, I use Heidi, and it's always there, and annoyingly so, to be honest. Especially when I've just been chit-chatting with the patient about my life, and that's ended up in the notes as well. So
discussion about holidays and all those things.
Yeah, holidays, good stuff, kids, the whole 9 yards. In fact, it's very therapeutic for me talking to patients.
Sam, don't start. I was going to go back a little bit to that bit about DHBs letting doctors know how long the wait times are, because we've specifically asked, and it's really hard to get those figures out of the hospital to say, tell us how long an X-ray is going to take, tell us how long an ultrasound is going to take, because we need that information for informed consent for our patients. But obviously from the hospital's point of view, they have concerns probably about if that gets into the media, or if, what public perception would be if the real wait times for an orthopedic 3 is out there. But I do think, I don't know if there's anything the HDC can do, or any of us can do, to encourage that transparency, because I do think that's a little bit that's missing at the moment in order for GPs to be able to properly inform their patients.
Because we can't complain to the HDC that we can't give informed consent because we don't have the information we require.
No, I mean, to some extent it may come back to me being more frank in my opinions, to ring up and say what's the likely wait going to be, but that is a huge burden, additional burden on already constrained workforce.
That brings into question, what's the role of the GP? What do you, in your opinions, feel that the responsibilities of the GP to monitor the patient while they're on the waiting list, and then to write back to the hospital, because that's quite a time-consuming burden when you've already pressured for appointments.
Yeah, I think there's certainly a responsibility if there's a change in the patient's condition, particularly deterioration, then that might alter their prioritisation for an FSA. Then I would be critical if the GP did not act on that and send an updated referral. So a case in point was a gentleman with a squamous cell carcinoma of his face. It was getting progressively bigger and bigger, and then developed a nerve palsy, and this went on for 3 or 4 months, and there was no updating to let the hospital know that these were now signs that this was getting significantly more invasive than it had appeared at the start, and this guy ended up losing half his face essentially, which he may have done anyway. But I think that there was some responsibility for the GP to recognise, hey, this patient's priority should have changed because these things are happening. Therefore, the only way that the person doing the triage at the secondary care is going to know is for me to inform them.
But often the patient doesn't come back, and so you don't know that the situation has changed, or that they're coming back about other things. They're coming back for their blood pressure tablets, and and actually you're then thinking about their blood pressure, and it's very hard to sometimes monitor those situations in the context of a 15-minute appointment about something else.
Absolutely, and I think again it comes back, I guess, to quality of notes. Looking at the previous consultation notes, at least the previous consultation notes. So I see this picture quite often with delayed diagnosis of ovarian cancer, which often subtle, non-specific symptoms. You've sent the referral in. There's a likely wait of 2 or 3 months. But what seems odd to me sometimes is that there's been no inquiry. How are your symptoms, even if they'll come in for something totally different? When the patient might then say, well, actually, I've now got X or Y. And that can sometimes stem back to the original consultation where the patient wasn't given appropriate safety netting advice, say, or explicit instructions on, if these things happen, then you must let me know. And again, documenting that, if you've given that advice, document it, because the patient may not take any notice of it or might forget it. But if you've done it, then that's a significant an action that you've taken.
So can I just ask you to clarify? I mean, I agree that we need to be documenting our safety netting advice. I think that's really important. But are you critical of GPs who don't ask about those vague symptoms that you've sent a referral off for when they've come in for other things?
I mean, again, it comes back to the context. But let's say the patient with vague symptoms that somewhere way down the list of your differential diagnosis is ovarian cancer, and you therefore make a referral for an ultrasound, say, versus somebody who you're actually quite very concerned that there might be an ovarian cancer present. So to me, I would be possibly more critical if there wasn't inquiry with the person you had high suspicion of cancer
when they come in for something else.
When they come in for something else versus somebody who had very vague symptoms that could well have been something totally different. So it is, again, it's nothing, there's no blanket principle that I apply. It's very much more, again, if I was sitting in the chair and this was happening, what would I be doing?
That brings us on to the continuity of care aspects, and I wonder whether you've noticed any difference between, if it's a single doctor caring for that person versus someone who sees a different clinician every single time, the nurse practitioner one time, different GPs, the locum the next, etc., etc.
Very much so, and I think practices, at a practice level, there needs to be some process in place. I'm not sure exactly what the process is, but if we're trying to enhance continuity of care, and if it's a fact that the patient's going to see someone different every time, the quality of notes needs to be really good. But for a patient coming in frequently for the same problem or sequentially for the same problem, there really needs to be an agreement within the practice about how this is going to be managed. So a practice could potentially be vicariously liable for not having processes in place to enhance continuity of care. And I think I'm not sure if the practice was breached or not, but a case I saw where this woman had been coming in with urinary symptoms over a period of a couple of years, and had hematuria on each occasion, sometimes a pyuria, negative cultures, but was treated as a UTI on each occasion. 6-7 times over 2 years by different providers every time. Nobody looked back to think, well, this is odd. She never actually has grown anything, and there's been this persistent hematuria. And of course, she had advanced bladder cancer by the time she was diagnosed. And I think it's a real situation where fragmentation of care and maybe not reading the previous notes or just not considering the overall picture has resulted in harm to the patient.
it seems to me that in a lot of those clinic type situations, those are the doctors who particularly are working under huge time pressures. And I always used to find that, when I was working well to time, I'd always have a chance to read the notes beforehand. Inevitably, if I started running behind, those were the times I wouldn't read the notes because I was trying to catch up, and always something would trip me up. There'd be something I should have asked and didn't do. And,
Well, I know there's been a defence in one case where again, the fragmentation of care meant that the provider didn't have an opportunity to read the notes because of the time pressure they were under, and missed a highly elevated BNP in a patient who died of heart failure, 48 hours later, and had been investigated for heart failure by somebody else. But
I know that case.
It just didn't flow. And I think in that doctor's defence was the fact that, the way the practice was set up meant she was just working under such pressure that there was no opportunity to read the notes. I don't recall whether the practice was breached for not having systems in place, but I'm sure there was adverse comment at least in that regard.
So do I take it that it depends on the clinical situation as to whether you will hold a clinician to account for not chasing a referral?
I don't think it's possible to make a blanket rule or a blanket principle. I think it really just is so dependent on so many things.
I just worry that the standard of what is required of a GP nowadays compared to 10 or 15 years ago, now that the electronic systems are there, when we sent a referral off 20 years ago, it went off. Patients did get seen in those days, but actually there was no system for chasing or recalls or any of that, and so there was no expectation that GP should have to do that. And now they've got these whiz-bang PMS systems that can do it all. They've created an obligation for themselves to actually do what the system allows them to do, which hasn't translated into the hospital doctors who don't have the systems that allow them to do recalls and chase all their letters. They don't find out whether we got the outpatient letter that says, please, can you change the medication? Have they got if a physician sitting in outpatients writes to a GP and says, I want you to change this, this and this, do they have any obligation to check that the GP got it and acted on it?
Well, not that I'm aware of. Or if
doesn't that seem kind of not fair?
I think on many levels there are significant differences in the perceived obligations or actual obligations of GP using the technology we have in primary care to track results, to ensure inboxes are actioned, et cetera, et cetera. I'm shocked sometimes with what I see in secondary care. So, for instance, a case the other day where nobody had, this physician had gone on leave. No one had looked at his inbox, if you like, for 3 months or something. And there was no system in place for that to actually happen. If it happened in primary care, it wouldn't be very much frowned upon. Things like the corridor conversations, and that's one of the issues, I think, in the terms of primary secondary care, that we're expected to document any conversation that has a clinical has a clinical context. And certainly if you're talking with a physician or arranging an admission over the phone, definitely document it, because it's not going to get documented at the other end. Advice given from a secondary care clinician, verbal advice over the phone on management is not going to end up in the patient's hospital notes. And I understand, the technology in the hospital is not the same as we have in terms of how easy it is to bring up some patient notes and to write in them. But yeah, there are significant differences in expectations and actual processes.
I worry about where it's all going to end, because I do think that issue of when you've written your referral letter, you've got an acknowledgement, so they've got it, and a situation where the patient's situation hasn't changed. They have an ongoing chronic cough, but actually they still have an ongoing chronic cough. And you're thinking, oh, look, I'm worried about that x-ray, but, I'm waiting for the respiratory physician to tell me what they think it is. I've got an acknowledgement. I know they've got it. So I'm worried about that cough. Have they got interstitial lung disease? Have they, what's going on? So I said a recall for 6 weeks, and no, they haven't been seen. And then do I push it forward 6 weeks and have another look and chase it again in 6 weeks? The actual time, sometimes by the time a patient is seen, you have looked at that referral, chased it, tried to find out what's happening, where's the waiting list, are they on it, what have they been prioritised? You could have done that 6 times. And the time that has taken, all unfunded, it's getting worse. And we don't know when to set that recall for, because we don't know when it might happen.
Yep. I have to acknowledge that it is extremely difficult, and it's unfair in many ways. But I still feel, look, we are there to advocate for our patients, and we have some responsibility to ensure that they have safe and appropriate care, even in a constrained health environment. I think the answer is going to be what should have happened 20 years ago, which is a unified single health electronic record that anyone can look at.
They've been promising us that forever.
I know, honestly, it's just, I don't know why it has taken so long and when it will actually happen. But that would very much enhance continuity of care and just make everybody's life easier, and I suspect the patient will have a safer health journey as well.
But following up on your patient advocate sort of approach, why does that not apply to the hospital physicians who have received the letter, accepted the referral, so they've basically taken on a degree of responsibility for following it up and doing it, and yet there doesn't seem to be any kind of real impact on them if they don't do it?
That's right. And I guess that's almost a fault within the system or the complaint system in some ways, in that it seems to be in secondary care that the provider at a higher level, a Te Whatuora regional level, is held responsible rather than the individual clinician. And I think part of that is the system that the clinician is working in, that it's probably easier for them to blame the system. And often, very often, obviously, it is systems issues rather than any omission on the part of the individual clinician. But it's much easier to look at the sort of micro medical practice and their systems than it is to look at Te Whatuora and their systems. So in some ways we're a victim of our own efficiencies, which is what you're intimating.
That's what I actually look at. I look at our great systems that actually can set recalls but actually it's a rod for our own back, because the fact if we were a paper system, we wouldn't be able to do it.
That's right. I'd like to think that ultimately the patient has benefited from our electronic systems. I don't know that there are the stats out there to prove that, but I would like to think there are fewer missed referrals.
I think there are aspects of medicine that have got a lot better with it, but I'm just worried about what it means for general practice, particularly if it's got to be a clinician who does look at those notes and says, do I need to be worried? Do I need to chase it? And you're actually saying that we're using clinician time to do that when there's a 3-week wait to see a doctor. There's a price to pay, isn't there?
Absolutely.
I would have hoped that it becomes a significant mitigation. The fact that there is time pressure, the fact is that the wait is at the hospital end, not at the GP end, and to expect GPs to continue to check it up. And I've exactly the same. I've got tasks that I just keep pushing out and pushing out.
Yeah.
And what do you do? And I would have hoped that would be a significant mitigation.
Yeah. Well, certainly, I think if you've received confirmation this patient that the referral has been received, I think the wording I often use is that I think it's a reasonable expectation that having received acknowledgement of receipt of the referral, the hospital would have appropriate processes in place to ensure the patient is then seen within a reasonable length of time. If during the subsequent 3-month wait, the patient's been in 3 times, with worsening symptoms or whatever.
Yeah.
Different story to if you've had no real contact with the patient over that time.
Yeah. And I think your point earlier that the degree of concern you have about the patient at the beginning, so if you really are concerned that it's cancer, then that changes the equation versus someone who's got a chronic osteoarthritis of the knee. It's got to the point where they need to be seen, but it's not going to change dramatically in the 3 or 6 months.
That was the exact wording I had written down here.
Oh dear.
We're comparing suspicion of cancer versus OA hip, knee rather than hip.
Right.
Yeah. I just think that it's the fact that, to be honest, you probably do need a clinician making the decision about the significance of the wait. And I just think that there aren't the resources in general practice to do it, so that it has become an expectation which I think isn't sustainable.
Well, you're right, and I think it needs to change. Which I think that eventually when we get a shared electronic health record that's efficient and fit for purpose, things might change. The other thing we can do more of perhaps is give the patient a bit more autonomy in this whole process as well. And that obviously depends on the situation and the degree of health literacy and the degree of health anxiety, those sorts of things. But, sharing responsibility with the patient, which comes back to, being explicit about if you haven't heard, by a certain length of time, or if your symptoms get worse, make sure you come back in, etc. But, at the risk of burdening secondary care, I think it's not unreasonable to encourage the patient to advocate on their own behalf by contacting the hospital, not as a replacement for your monitoring of the situation, but giving them a bit of autonomy to advocate for themselves as well. So, in many things, many complaints that I see, if there'd been more involvement or autonomy given to the patient, things might have been different, particularly around abnormal results. Say, if many patients now have access to their results through the portal, and if they've been given appropriate education and are health literate, then they can share responsibility for picking up something that might have slipped through when the file button was pushed in error or whatever. But I don't know. Getting back to the other issues with secondary care.
All right.
We go.
There are more, are there?
So I think discharge summaries are a bit of an issue, particularly when there are amendment after amendment after amendment flooding your inbox. And there've been cases. I think a case that was published relatively recently, where on the third amendment there was some significant piece of clinical information conveyed, but it was filed not realising that it was the third version with something critical in it. But the issues I see coming from discharge summaries would be more around making sure medication changes are transcribed in a timely fashion. So I'll often get complaints about apparently missed changes in medication, which are more at the minor end of the spectrum, but perhaps reflect not good practice there. Instructions for the GP, and that comes to that whole transfer of care issue, which thankfully I think that the statement from Te Whatu Ora really making it a bit more black and white.
Yeah.
So the issue is dealing with those complaints that precede the Te Whatu Ora statement. And in the past, I've generally kind of taken the same line as has come out in that statement in terms of responsibility. That certainly, if there hasn't been a formal handover of care, I would be critical of secondary care for not, rather than primary care for not doing the task that was assigned to them or whatever. But there are situations, I think, where there hasn't been sufficient advocacy on behalf of the patient when obviously this is a very critical task or result or whatever, and there's been no attempt to clarify, well, who's taking responsibility for that.
So the part of the secondary responsibility remains with primary care. Is that what you're saying?
In some situations, probably a minority of situations where there is a critical result and it's not clear who is to be handling that result, I think there's still some responsibility of primary care not necessarily to undertake the task, but at least to clarify who is doing this.
I think that's been understood for a long time, but maybe not by all our members.
Yeah, I mean, even though the statement by Te Whatu Ora has been out for a while now, I think it hasn't made its way around all the hospital employees. That's where the difficulty lies. So I think there's a lot of frustration still amongst primary care clinicians that we still carry the can. And so it seems harsh, really. I mean, I agree with you that if it's a clinically significant result or test or something that we ought to do, we ought to follow up on that. But, when you think about the pressures and the time constraints, it still seems harsh to be criticised, if that makes sense.
Yeah, I acknowledge that. And I think, again, because it's context specific, that will affect things. I think even within our colleagues, things like, do we want to get results from the hospital that we haven't.
There's variability, isn't there?
There is variability, and that's possibly less of an issue now than it once was since the Whare Ora statement. But still, looking at results of test results you haven't ordered takes up time, clogs your inbox. But we, in some ways, by having at least some results come through to us, that is a backup in terms of patient safety. So again, I don't know. There might be a middle road there. I'm not sure.
Can I just talking about inbox, does a GP have to look at their inbox every day? What's your view on that?
Well, no. Well, not. I don't. I take weekends.
I'm so glad to hear that.
I take weekends off generally. It comes back to the clinical situation, I think. So, I think obviously, you've got someone that you've seen with atypical chest pain, and there's a troponin coming in, or they've got a swollen leg, there's a D-dimer coming in. You're not going to let that sit for 3 or 4 days and ignore it. And you'd expect, I think, a totally unexpected abnormal result. So I've been phoned before I've seen a kiddie with a sore throat, and I've been phoned saying this kid's got leukemia, by the lab. So that's, I think there's some expectation that a critically abnormal result you'll be notified of. That comes back a little bit to what I see as a bit of an omission in my colleagues, which is actually putting clinical data on blood test request forms. So I see far more often than not just blank request forms with tests requested. And of course, we come back to the PSA issue of someone who's had a radical prostatectomy, and the lab doesn't know that a result of 0.5 is actually highly abnormal, so it doesn't put any comment.
It's interesting. I had a call from a doctor the other day who had a very, very busy Friday clinic and hadn't looked at his inbox before he went home on Friday, and then was doing his inbox on Sunday and found a significant result that if he had seen it on Friday, he would have actioned, and the patient had actually got admitted on Saturday, it turned out, and we had this exact discussion. I think a lot of GPs on the Friday afternoon, it's a crazy busy time. Everyone's coming at you from every direction, and if you finish seeing patients at 6, the last thing you want to start doing is your inbox on a Friday afternoon. And I kind of thought, well, actually, I think it's reasonable that you don't have to do your inbox at 6 o'clock on a Friday night.
Or can someone do it for you and just look for the red ones? Which raises the whole issue of who.
But then do you have to do that every day? I just think, again, we're putting more and more expectations on general practice that aren't put on other specialities. If a surgeon sees a patient in their rooms and orders some blood tests, they often won't necessarily see those results till they're back in their rooms next Tuesday.
But they would have see them into you, so they'll be in your inbox.
But they're not allowed to. They're not allowed to. But you know what I think that we got to be really careful that actually general practice is not an urgent. It's not ED.
Yeah.
We have to make general practice doable.
Yeah.
We have to keep
it's getting that balance, I think, between patient safety and doability. And there is a sweet spot somewhere.
Yeah.
I'm not sure if it's 3 days of not looking at your inbox or 4 days or whatever. But yeah, it's not necessarily every day.
I think what's important for us, for our members' sake, is really to understand that you don't hold it to you must check your inbox every day, and that it really does depend on the clinical situation. I think that's quite important.
This leads on to the question of informing patients of results too, doesn't it? And again, there's a significant difference between what is expected of general practice versus the secondary care. So it's not uncommon for example, a surgeon to order a test, but the patient doesn't know about it until their next clinic appointment in 3 months' time. But if I do the test and it's significantly abnormal, I'm expected to inform them within a much shorter period of time than that.
Yes. Well, I think with the patient portal now, I think it tends to be prompter informing of results because the patient's going to look at them as soon as you push the file button. Anyway, again, it's context specific. So this morning, yesterday morning, I was looking at a case of a lady with 3 weeks of diarrhea and rectal bleeding. So hasn't been having these symptoms long enough to get direct access colonoscopy, and quite appropriately a fecal calprotectin was done, that was significantly elevated, but then wasn't acted upon. Wasn't communicated to the patient or acted upon until the patient came in 3 weeks later, not because she'd been asked to, but because her symptoms were worsening. So I wouldn't regard that as being good practice. But if hemoglobin was normal, but ferritin was low, for example, or iron stores were low, then I wouldn't be critical. They weren't called in for 3 weeks, because I wouldn't regard that as
right. So it's context
sort of
specific.
time as time critical.
That makes sense. Can we just quickly talk about delegation of the inbox? Have you seen any cases, any issues with that?
Yes. So the delegation.
That sounded like a very weighted yes.
Well, I mean, it's basically 3 or 4 cases of missed abnormal PSA in someone that's had.
Okay, so it's the PSAs.
Yeah, the PSAs. But I think what that illustrates is the risk of looking at a result when you're not aware of the clinical context in which the result was ordered or the history of the patient. And if you're going to be delegating, I think you really need to have very robust systems in place and good practice yourself in terms of coding and alerts and things like that to make sure it's safe. So, I give the example of a patient, who's got vague abdominal symptoms. You do a hemoglobin, which you don't look at because someone else is looking at your inbox, and it's 126, so not too bad, but the one 3 months previously was 151. So that could be doesn't appear significant based on that single result, but could be significant in terms of what you think could possibly be going on with this patient. So but again, it comes back to that time issue. I think if you're the one that's ordered the test, you're usually quite aware of the clinical context. You don't actually need to look at the patient notes. You just can handle them. And it's a big ask for someone else doing your inbox to go into the patient notes for every result and look at their recent medical history and disease coding. But possibly that's what needs to happen if you are delegating.
There are a lot of people, I think, using med students, retired doctors, healthcare assistants, nurses. I think a lot of people are delegating, and I completely understand why. And I'm not aware of specific cases, but my expectation is that there is certainly risk involved.
Yeah. I think there is, and if you've shown you've taken significant steps to mitigate that risk, and an error still happens, you're far less likely to be criticised than if the person you've delegated to has been given no instruction or anything other than just do my inbox, please. And then an error is made.
I do have to say, if you actually read the HDC website, the chances for GP cases, and you search GP cases, it feels like almost half of them are PSA cases. It's a huge number of where GPs get breached is about PSA results. And so I kind of always think that the advice should be, don't let anybody file your PSA results unless they've got some very good boundaries of what they're allowed to do. Yeah. But it will be, it's one of my pet things is I really love it that the lab could have 2 different boxes, one for PSA screening and one for PSC monitoring, so that the doctor could choose which they were checking rather than actually just checking PSA and getting different normal ranges for them. It seems like a very simple fix.
Yeah, because it's not just post radical prostatectomy. It's that whole velocity of increase even within the normal range, those sorts of things.
Yeah.
So, but I think just do your own PSAs.
Do your own PSAs.
It's probably the best piece of advice.
Following up on that, I had an interesting case relating to PSAs, but it led back to your comment about patient autonomy and I guess the relevant weighting that's put on patients' decisions versus, what a doctor might advise. And we've often seen the case where it seems that the patient has made a certain decision not to follow up on whatever the abnormal result might be. But then when things have gone badly wrong, a relative complains, and the doctor is suddenly left incredibly vulnerable because, if you follow the guidelines, they supposedly haven't followed those guidelines. The case I had in mind was a gentleman who had an abnormal PSA. He was in his 70s, late 70s. It was slowly increasing. Every time the doctor saw him and discussed it and would give him a form to repeat it, he would never get it done. And he was referred off and decided not to go to referral. So all those things have been done. And he clearly decided he didn't want to have anything to do with his PSAs and he was going to just let things happen. But when he got so sick that he could no longer make decisions, his wife then got involved and she complained because it looked as though no action had been taken.
So I think in that case, it's really important that if your perception is, and this is a prime example of when I wouldn't apply a guideline because the patient's obviously, if the patient doesn't consent, then you can't force them to get tests done. But I think it's really important when perhaps guidance can't be followed because of patient choice that you document this has been discussed. The risks of not taking this PSA, of not monitoring this PSA have been discussed or whatever. And if you've got that documentation, that's hugely supportive in terms of saying, well, it's quite patient choice. It doesn't. If the patient's competent, if they make to you what seems an unreasonable choice, if they're competent, it doesn't matter. That it's their choice.
But it's the documentation.
The documentation is critical, I think. And
we always come back to that documentation.
We do, yeah. But that's exactly one of those examples where you kind of don't think, it's not forefront of your mind to record. I've had this discussion with the patient. They clearly don't want to, because sometimes they don't actually, expressly say, I'm not going to follow up. They nod and then nothing happens. Yeah.
And PSAs, it's still, despite what the PSA support people say, it's still a very grey area in terms of benefit versus risk, etc. Isn't it? So.
Well, we've had another really interesting discussion for this second podcast. Thank you, David, for your time and your thoughts and opinions. It's been really helpful. And thank you, Lucy and Tim. And thank you to our listeners as well for listening to this podcast. I hope it's been helpful. We will be having part 3, which will come out in a couple of weeks, and we look forward to catching up with you then. If you like the Medical Protection podcast, please subscribe and leave a review. And if you would like a podcast on a specific topic, please email newzealandpodcasts@medicalprotection.org.